Okay, great. I have stock ownership in Invitae, which does some of the genomic testing that I'll mention. Not the only company that does it, but that's my significant disclosure. So we're going to talk about common genetic syndromes associated with prostate cancer. We'll talk a little bit about who benefits from testing, and then we'll talk about some benefits and limitations. And I'll go through the current guidelines briefly. So whenever we talk about genetic testing or genomic testing, it's really important that we distinguish somatic from germline. Somatic are the mutations in organ tissue resulting in malignant growth. We're all familiar with common somatic tests. Somatic mutations in general are not heritable, although we should put asterisks behind that because some can be. The somatic mutational tests that are in common clinical practice are Oncotype DX, Polaris, and Decipher. Germline testing, this is the heritable genes you get from your parents. The inheritance of these syndromes is Mendelian genetics. When we talk about high penetrance genomic syndromes, those of us that went to medical school, you'll remember autosomal dominant. Autosomal dominant and high penetrance are synonyms. That's really the same thing that we're talking about. And germline mutational defects are heritable. So genetic tests in prostate cancer, this is really can be obtained, the testing can be done on any tissue. Cheek swabs and blood tests are most common. By definition, this exists in less than 5% of the general population. Typically involve genetic changes in coding DNA resulting in an altered expression of a functional gene. Common examples, BRCA. We're all familiar with BRCA2. Usually, as I mentioned already, Mendelian inheritance pattern. Examples of testing companies are Invitae, Color, or Foundation. And we'll talk a little bit about the genes that are commonly or should commonly be tested for patients with prostate cancer. SNPs are also inherited and part of your germline mutation. SNPs in general are in the non-coding portion of the DNA. They usually are not associated with biochemical changes that are measurable. They're usually not actionable genes that we can identify. It's simply patterns of inheritance that can be easily identified. And we'll talk about a genomic test that uses primarily SNPs rather than the genes that like BRCA. So who should be tested? So fundamentally, people that have a personal or family history that's suggestive of an inherited syndrome, and that's family history of multiple people in the family with cancer, and that could be men or women. The test can be adequately interpreted. That means that the test is valid. It can actually tell you whether you have a syndrome, and it should influence care. These are not really for entertainment. You know, there's a lot of genetic and genomic tests available that are kind of interesting, but high-level medical testing should be done to inform therapeutics. And of course, we'll talk a little bit about how for advanced prostate cancer patients, now we have agents that should be directed to people who have some specific genomic syndromes. So in general, this kind of testing refers to germline testing of high penetrance or autosomal dominant genes. It's different from somatic or tumor-acquired mutations. So features that suggest an inherited syndrome: cancer at a young age, multiple different cancers in an individual, cancer in both organs where there's paired organs, so bilateral breast cancer, bilateral kidney cancer, several close relatives, mother, daughter, sisters with breast cancer, unusual cases of specific cancer types. The best example is probably breast cancer in a man. Presence of birth defects and non-cancerous benign skin growths that are associated with genomic syndromes. We're all familiar with a number of the neurocutaneous syndromes like von Hippel-Lindau disease that not only are associated with kidney cancer, but characteristic cutaneous syndromes. And then sometimes being member of a racial or ethnic group that's known to have an increased chance of hereditary cancer. The best known is Ashkenazi Jewish families are now in the NCCN guidelines because of the increased risk of BRCA1 and BRCA2. That's actually a huge population of Americans and Europeans, so that brought a big group of people into recommended testing. So when we talk about frequency of genomic abnormalities, we often talk about this Pritchard article, which is really a landmark article in the New England Journal of Medicine looking at a large group of men with metastatic prostate cancer and did germline DNA sequencing to assess the frequency of genomic syndromes. And there were 11.8% of men had identified DNA repair gene mutations. And that surprised everybody. This was kind of a landmark study that got everybody's attention. We thought the penetrance of common DNA repair genes would be in the 2 to 4% range in the population. It was 3 times that. So, and now that we have actionable therapeutics for people with DNA repair gene abnormalities, this now really becomes common clinical practice. If someone has high-risk prostate cancer or metastatic disease, we now recommend genomic testing or genetic testing because it may influence, it will influence therapeutics for those patients that are positive. So this is a complicated slide, but let me, this was a conference that happened now 5 years ago in 2017, which was a consensus conference of a group of experts that got together helping us think about who should be tested. And these are a bunch of family history syndrome recommendations, and they recommend all men with metastatic castrate-resistant prostate cancer. These are family history of genomic syndromes, and these are ultimately have made it into the NCCN guidelines. And again, this was a little bit complicated around screening, early detection, advanced disease, and metastatic prostate cancer. As I'll show you, the NCCN guidelines have narrowed this down and refined it over the last 5 years. So how about family history? You know, family history heavily influences men with prostate cancer. If their dad had family history, they're much more likely to be treated than go on active surveillance. They're much more likely to select more aggressive treatment. So family history is a really important detail, but the majority of men with a family history of prostate cancer do not have a high penetrance genomic syndrome. They may be able to be identified based on SNP-based testing. So, and the challenge with family history is it's subject to various challenging, including recall bias, adoption, education, number of male family members. Does everyone get the same risk? So only 7% of the patients that were in the PLCO, the large American screening trial, actually had a positive family history. In our diagnostic population at UCSD, it's 28%. So now that this is in the common know for patients, many more patients will say, yeah, I do have a family history, secondary relative, et cetera. SNP testing significantly outperforms family history as a predictor of prostate cancer risk. So this is just from one SNP test that's called PROMPT that was actually purchased by Invitae. This was actually developed by one of our faculty at UCSD. Many of you know Dr. Kareem Kader. This shows the absolute risk of prostate cancer in PLCO. And again, it was about 13% of the patients in that trial had prostate cancer. This is the family history distribution. This is the frequency. So again, as I mentioned, relatively small group of patients in the study had family history. But if they did have a family history, their chance of having prostate cancer was 28%. If they did not have a family history, slightly lower at about 12%. When Dr. Kader did the SNP-based testing of this population, he could actually distribute the risk of cancer based on the SNP profile and their family history. So patients in this group with these very high-risk SNPs, he could identify a population with over 30% chance of having prostate cancer. And the patients with a very low, very favorable SNP profile had a very low risk of having prostate cancer. And this is the PGS distribution of this population. And what the potential benefit of this is, you know, perhaps we should screen less frequently or do less screening in this low-risk population, be standard recommended screening in this intermediate risk population, and this high-risk population, you know, probably requires more aggressive screening because they're at very high risk of clinically significant prostate cancer. So we hope this is re-released by Invitae soon and commercially available. They're not actually marketing it right now, but we hope it's back being heavily marketed in the coming years. So here's the NCCN guidelines. Too much to read, but I just want to point out a couple Got a bird helping me. Point out a couple of things. Pre-test considerations, this is about family history. If testing, this is the series of genes recommended. Hoxbox, ATM, BRCA, and the mismatch repair genes are the genes to remember. And then anybody getting tested really needs genetic counseling, and there's not enough genetic counselors in America now. These are the 2023 guidelines. Again, this is a little bit complicated, the next page of the guidelines, but it really talks about what specific elements of family history drive testing, how about first and second degree relative, etc. And now this is the new part of the guideline. Anybody with metastatic prostate cancer or very high risk or high risk clinically localized prostate cancer should get tested by the guidelines. So now this is a much larger population of patients, including those with localized disease that with high-risk features should get tested. So in summary, screen men with a family history of prostate cancer or genetic syndrome associated with prostate cancer. SNP testing does a better job than family history for distributing risk. Do genetic testing for all men with advanced cancer and high-risk localized cancer. These are the recommended genes, and I put them in the talk, so these slides are available to you. I hope that's useful to you. Thank you.